All right, so what we're going to be talking about is BPPV, and this really is going to be a very, very specific lecture. This is not meant to make anybody an absolute pro at this. It is giving everybody that listens to this some basic skills on how to treat the most common forms of BPPV, which stands for benign paroxysmal positional vertigo. We're going to be focusing on the most common types and primarily posterior canal. We're going to cover maneuvers for the posterior canal, and we're not going to delve into anything else in the scope of this lecture, but it's going to be something that you will see a lot of videos. You will see where those videos are housed for you to go back and re-watch them. And there's also several YouTube links that I think are very, very good and very basic and kind of summarize things really, really well. So that's the purpose of this, is to give us a working knowledge of how to treat the most common forms and the most typical types of BPPV. So obviously, before we start anything, hopefully everybody has a general idea of the anatomy. What we're dealing with here is the vestibular system. As you can see, let me get a pointer up here. So the vestibular system being this area right here, okay, in the inner ear, behind in the bone of the head, and we will talk about the specific parts of it here in just a second. I like to put this in here because when I found this out, it was like an aha moment for me. Because when you deal with people with vestibular problems, and if you ever had vestibular problems, it really messes you up. And the vestibular system literally is the size, the entire system is the size of a dime. So I think that makes us really appreciate how powerful of a system this really is, because it can overtake our entire life, yet the thing is so, so tiny. So let's talk about the actual semicircular canals and then the general anatomy. When we're talking about BPPV, we're focused on the semicircular canals. And I did send handouts to your emails, by the way, after very late, so hopefully you have those. We're going to be talking primarily about the posterior canal right in here, but and I will show you some other pictures of it in a second. This is a picture taken from an app on my iPhone called AVOR, and if you want to start getting familiar with this, I strongly urge you to download it. It's small a and capital VOR. It's a really fun little app, and you can move this head back and forth and see the crystals move. It's really, really a great way to learn. But that's where this picture is taken from. This is a picture, actual anatomy of the vestibular system that was taken from one of the lectures that I went to, and it's here's the reference for it. But this really makes you appreciate the fact that all the pictures we see make it look smooth and make it look like, you know, it's just these perfect tubes. Well, they're not. And when you see this, and you see these enlarged areas right here, this is where we have the cupula. But I think it really makes you appreciate that it's kind of, these aren't total straight planes of motion. They're kind of curvilinear. And if you see what's happening here, that's why, and everybody's anatomy is a little bit different, and it's kind of bumpy. So you can see that sometimes when you aren't successful in an Epley maneuver, if you think of this picture, you'll be a little more free and not being so rigid with your head positions, but then you can change it a little bit and shake things, because things can get stuck in those little cracks and crevices, and things can adhere to the sides of the canals. So I think this just really made me appreciate that it's not really a perfect tube system that we always see diagrams of, trying to illustrate what's going on. And this is why sometimes some people get a great response and other people don't. You're like, gosh, they're just not converting. I don't understand why I'm not getting these things around the turn. Well, it's probably because they're just a little bit off angle. So sometimes slight changes in head position do make a difference. So general anatomy, again, for the sake of this lecture, we're just going to talk about the utricle. That's where the otoliths are housed. And we're going to talk about the semicircular canals. Now the ampulla, that is that little enlarged area right here at the end of each canal. Okay, up in here. That's the area that has the cupula in it, that has those little hair cells. The canals themselves, as you know, are just filled with fluid. And then they have a little sensory cell in the ampulla at the end of the canal. And then the utricle is where we have the otoliths, 2 of them. And that's where the crystals originally break off from and then can float out into the canal. So again, because there's a lot of weird words that maybe we didn't hear before, what you need to know is the semicircular canals have the ampulla in it, and the ampulla has the cupula in it. And the cupula is where the hair cells are. So kind of boom, boom, boom. The utricle is where the otoliths are, and the otoliths are ones that have the crystals. And the crystals are okay if they're on the otoliths. They're not okay if they're in the semicircular canals. And that's how I explained it to my mom. Because she's like, what is this? She doesn't speak English real well. And I try to explain it to her, and that's pretty much it. You say, you got these canals, and that's how I explain it to all my patients. And it's very, very important for you to give them that visual, because once they get it, it's not all that hard to explain to them what we're doing, because it does seem a little voodoo-ish. They're like, oh, really? You're going to get rid of my dizziness by making me roll around here. And, you know, to be honest, I think the first time any one of us heard of this as therapists, that's the first thing I said, oh, really? Like, this is going to work? I mean, there's not many things we do where we can get that kind of response and that great of an outcome like that. And that's part of what makes this so fun, is that when you do it right, and you guys in Broomall have seen the little lady we treated, Erin and Dara, I mean, big differences. And when you nail that, I mean, it's awesome. And, you know, in our population, in the elderly, they're the more complicated ones to deal with. They're not the straightforward young person that comes in after work and says, you know, I just have a little bit of dizziness, you do a maneuver and they're great. Our people have a lot of other problems, anatomy, range limitations, which we'll talk about. It poses more of a challenge, but we do need to address it. All right, so again, just reviewing one more bit of anatomy, the bony labyrinths. I think that's also very important for us to understand that they are bony. And their purpose is to detect angular acceleration. And I explain that to people. I think it's important for them to know. And that all of these canals are bathed, are filled with fluid, and they all connect to this main chamber, which we refer to as the utricle. And the ampulla, that's the bulbous enlarged portion at the end of each canal. That's where the cupula is. And then the cupula, the enlarged area, that's where the little cilia or the hair cells are, and those are what cause and wreak the havoc when we experience BPPV. All right, so now here's a video. And I think this does a really good job. So thumbs up if you can hear it, thumbs down if you can't. I think it's real important for us to understand the prevalence of BPPV in the general population, and then also in the elderly population that we deal with. So you see that 9% of the geriatric, it's actually kind of 9% of the population in general actually has BPPV. But 78% of the elderly that have experienced a fall have BPPV. That's really high. So this is why, as I'm going out and spending time with those of you in the clinic, you hear me harp on this. We cannot have anybody that's referred to us for falls, which is a lot of our patients. We cannot not screen them for BPPV. This is well within your scope of practice. It's just part of an assessment process. A lot of these patients, like the little lady we treated, I forget what her name was, but she didn't even say she was dizzy. So sometimes, you know, they've had it for so long, and their sensory input is so oppressed in a lot of ways that they're like, oh, it's not, it's not that big of a deal, and they might have had it for a long time. They may not even feel dizzy. I know personally I have BPPV and I am never dizzy. I just lose my balance. That's how I know I have it. So there's all different presentations of this, and that's why I would like us to get to a point at SAVA that when we have somebody referred to us for falls, this is a standard part of our assessment to be sure that the vestibular system is not one of the contributing factors. And as you've done the balance modules, you know now, those of you at Broomall and Bo, you've done them too. Adele, George, you guys are going to be, oh, Pradeep's on too. Hi, Pradeep. We need to make the standard, and we cannot just assume that the vestibular system is working right, because that could be our main culprit. And it's a shame when this is so easy to fix that we would have overlooked it and ignored it. And that's why I want everybody to have a basic proficiency on how to treat the most common form of BPPV, which is a posterior canal cupulothiasis. And if we get to that point, 60% of those patients' problems will be addressed that we were missing before. And then those of you that go on to pursue some more advanced education in vestibular will understand the different canals, the different types of nystagmus, different forms of BPPV. That's not what this lecture is about, but this is about to get what we see most commonly and to give us some tools so that we can at least be getting 60% or so of those patients that are out there. So what else could somebody's complaints of dizziness be if the patient is complaining of dizziness? Well, orthostatic hypotension. We're all well aware of that. But as you can see after each one of these, I'm going to put kind of what's the usual presentation. Does that mean it's that way all the time? No. But these are kind of some things you could ask. So if they're dizzy, you could say, well, is it a lightheaded feeling or is it a spinny feeling? Lightheaded is frequently hypotension or blood pressure problems, and it usually occurs with a change of position. So supine to sit, sit to stand. Medications. Well, as we know, a lot of our patients have significant polypharmacy going on, and the most typical side effect of the majority of medications that anybody takes is dizziness. So you're like, well, and that's a lot of times what it gets written off for. They're like, well, they're dizzy, well, they're old, and they're taking a lot of medications. What do you expect? Well, what I expect is for them not to be dizzy, and I certainly don't want them to be losing their balance because of it. But the key kind of question that I drill to when I'm trying to look at medications, is it constant in nature? Is it kind of always a low level right there? And is that a woozy or a lightheaded feeling as well? Medications are usually not that spinning sensation. A vestibular hypofunction, meaning that one side is not working as well as the other. It would be very difficult for you to actually do diagnostics for this, given the tools that you have in the clinic at your fingertips right now. We're not a specialty vestibular center, and usually ENTs aren't going to be doing caloric testing, but that's usually how you would find this out. But that will also be a complaint of a constant dizzy feeling. They'll complain of difficulty reading, scanning for things. They'll suffer from visual motion sensitivity. These people have a really hard time watching someone like me talk, who's doing a lot of this kind of stuff, because it's just too much visual information. That's referred to as visual motion sensitivity. And like TVs, they have a difficult time in cars. Not that our patients do this, but if they go to grocery stores or up and down the hallways with a lot of information, they won't scan. They'll keep their heads real straight. They'll look at focal points. Those are all kind of things that you would look for somebody with a vestibular hypofunction. And then, of course, there's cardiac problems, which, again, a lot of our patients do have. Atrial fibrillation, arrhythmias. So it's like, well, how do I tell the difference? Again, those may be intermittent, but they certainly are not positional. And that's going to be the hallmark one of the hallmarks we're going to look for with BPPV is it's positionally provoked. And then, of course, there's neurological, yet another thing that a lot of our folks have. They could have a tumor in their brain. They could have a bleed. They could have hydrocephalus developing, or they already have it and the shunt isn't working correctly. We have to consider all these things. But again, that's a more constant type of dizziness, and it's not positional. It's not only when they change positions, only when they look up. It's like they're all the time. So those are kind of your big areas on what else dizziness could be. So what are the hallmarks of BPPV? Well, first, it has to have a latency. So what does that mean? That means that it takes some time for the symptoms to come on. How long? 5 seconds, 10 seconds, sometimes 30 seconds. But it's not like the minute they tip their head up, they're like, woo, they'll go, oh, there it comes. So you have that little bit of a lag. And then the duration of the dizziness or the nystagmus is frequently less than 60 seconds. Now, I say frequently because you can still have BPPV and it can last longer than 60 seconds, but that's a different form of BPPV. But most of the time, the person will say, oh, there you go, and then all of a sudden they're like, okay, oh, it's gone now. Don't move me. Well, it's like, guess what? You're going to move them because you got those little crystals on the move. But the point is that that's usually what happens. Not a lot, ramps up really dizzy, and then tapers off. Why? Because those little crystals floated, and then they got to the turn in the canal, and they have nowhere else to go. And then they say, don't move me, and then they sit back up, and they float back the other way. And then they get dizzy again. It will decrement with repetition. So if you did a test for it, a Dix-Hallpike, for example, and then you sat them back up, and then you sat them and you laid them back again in a minute or so, the symptoms usually will not be as bad. So that's referring to it decrementing with repetition. So each time you do it, those crystals start spreading out in the canal, and the symptoms are usually not as severe. Are the crystals still there? Yeah, but they've spread out. They're not moving like a big wad of crystals or a big wad of sand in that canal. And then, of course, the most important, it's positionally provoked. So it is not constant in nature. They'll tell you, I'm fine right now. I'm fine sitting here looking at you. I'm fine. But when I lay down, oh boy, but it only lasts for a few seconds, so it's not a big deal. So then they just want to blow it off. They don't want to focus on the fact that maybe this could be a problem. And a lot of people actually don't get that intermittent dizziness when they lay down or sit up or bend over, or that little blast of feeling imbalanced, they don't understand that actually is contributing to their balance problem throughout the day. So it's very important to explain that to them. So what are the classic questions that you can ask? So there's a form called the Dizziness Handicap Inventory, and we have this listed on Rehab Central in the Balance Notebook. There's a short form and there's a long form. Each one of these items that are listed here off the long form, there's 4 items that out of, I think it's 30 questions that's on the DHI. On the short form, they're very specific to BPPV. There's actually been research done that shows that if they answer yes to any one of these questions, and if the more of them they answer yes to, you can, I think it's something like almost 90% specific that you can be confident they have BPPV if they're answering yes to these. So the research has shown that just that they're answering yes to these questions is diagnostic of BPPV, and then of course you would follow it up with the Dix-Hallpike. And so the questions are, do you get dizzy when you roll? Do you get dizzy when you bend over? Do you get dizzy when you look up? Do you have difficulty getting in and out of bed? Now, they may say, yes, I do, which a lot of our patients do, and it may have nothing to do with the dizziness. So then you have to drill into that just a little bit more. So on the short form, these are the very specific, and these I like to use these. Do you get dizzy when you lay down? Do you get dizzy when you sit up from lying down? Do you get dizzy when you reach or look overhead? If this is an outpatient, I frequently ask them, when you're reaching into the cupboard to get, oh, I don't do that, honey. Why not? Well, because I get dizzy. But sometimes you have to keep, because I don't do that. And then you're like, well, why don't you do it? It's not because I don't have anything up in those upper cupboards. It's because, oh, when I do that, I get really dizzy. So you have to ask that follow-up question. Are you dizzy when you bend over? Are you dizzy when you roll? So you see it's those positional changes that are very, very classic to BPPV. Okay, now here's another video. Again, let me know if you can hear it or not. I think this one should work. All right, I apologize for that. I don't understand why some of these are working and some aren't. So anyways, this modified video is, again, on Rehab Central, easy enough to access, and then you can take a look at that. But basically, I'm going to talk about ruling out vertebral artery, just like I explained it to you earlier. So just to review, we're going to lean forward like so, head up, and rotated and extension. But you see how my head's still on level, as opposed to having that patient sit up and then tip their head back. Now you don't know which one it is, whether it's a posterior canal problem or a neck problem. So that's how you're ruling one thing out over the other. Close this. So that's your link, and again, all on Rehab Central. So lateral canal problems. Lateral canal problems occur about 20 to 30% of the time. So more than they used to think, but significantly less than a posterior canal problem. There is a thing called a roll test. We're not going to be covering that, but there is a video link for that also listed at the end. But each one of these takes sometimes 5 minutes or so. We don't have enough time to do that. Or the bow and lean test. And a bow and lean test is that's exactly what it is. The patient just bows forward with their head, and then they let it sit there, and then they tip it back. And if they tell you that I get dizzy when I'm leaning forward, most of the time that is a horizontal canal, because if you look at the anatomy, the way the horizontal canal is, it's literally in the horizontal plane, in the transverse plane. And then when they tip forward, that's when those crystals would go. So that's why this bow test is pretty classic for that. And the nystagmus for a horizontal canal is different than the nystagmus for a lateral canal, a posterior canal. And hopefully, even if we don't have sound, I'll show you those videos because they're really pretty good. And then an anterior canal can occur. It's less than 17% of the time. You will only see this with extreme extension or a very, very prone head hanging position. Now, given that a lot of our patients sometimes sit around like that all day and they're looking down at the floor, sometimes prolonged positioning can cause this BPPV problem, because as we slough these crystals, if you're in a certain position, they could end up in that canal. But we're not going to spend any time talking about anterior canal other than it can be in there. But what you just need to know that is if you do enough posterior canal maneuvers, usually an anterior canal problem will convert and you can get it taken care of. And a lot of our patients will not actually tolerate the positions you need to treat that anyways. So we're just not going to be going there. So let's see which this one is. So this video here is the modified version of how you're going to do a Dix-Hall pike. So I'm going to run it, but I'm probably not going to do the audio. I'll just continue to talk, okay? Because I'm not going to sit here and worry about the audio since it hasn't been working. All right, so now, as you can see, I'm talking again, and you can't hear me now. So I'm going to be talking, I'm talking about ruling out vertebral artery. I'm just going to go zip it forward here because this is the actual vertebral artery rule out on her. Elbows forward, head up, rotated. And I'll just keep her there for about a minute and see how she is. I'll look at her eyes and see what I can see. And I'm not seeing anything on her. So now I'm going to pull this a little further forward. And I'm going to show you how I'm going to do a modified version. And this is what I'm going to recommend that we do on all of our patients unless we are absolutely 100% sure that we can do a full-on Dix-Hall pike on them. And the reason is if we're dealing with an inexperienced group of therapists, if you feel confident enough in your clinical decision making that you feel this patient could tolerate a full Dix-Hall pike, go for it, because you're going to get more, a better result. You're going to get more crystals on the move. That being said, if you're not feeling so confident, and Dara and I have done this on a few people, this is going to be that modified maneuver, which is going to be a side-lying maneuver, as you will see, and you will get about 60 to 70% of the time you're going to get the crystals moving on these people. So you see she goes into a side-lying position. Yeah, just like our patients, it's hard for her to move around. So we're going to get her down. Now the key here is you want her to be on her shoulder and then drop her head down to the mat. No pillow, and not partially on her back, on her side, and have her kind of looking up at the ceiling, as you can see. And this, again, all of these videos are on Rehab Central. I can look at her eyes here. I'm supporting my hand under her neck to give her some support, and I'm looking to see if she has excessive blinking. I'm looking for any nystagmus. And remember, those of you that have seen this, you don't have a lot of time because this could all be gone within 30 seconds. So preparation of the patient and getting them down and telling them what you're going to be doing and telling them they need to keep their eyes open, and you may actually hold their eyes open. You need to explain this to them because sometimes that's 30 seconds. That's all you have to see the nystagmus. Now, she doesn't have any here. She's fine. But this is a modified test. Now, if I saw nystagmus here, I would go straight away and treat it. And the reason is that our patient population has such a difficult time changing position that I'm not going to lay them down, sit them up, lay them down, sit them up, that we don't have that kind of time with them. They can only tolerate it maybe once or twice. So if I have a positive here, I'm going to then go into an actual maneuver, which I'll walk you through in a second, on from here, how would I do a modified maneuver as opposed to a straight on maneuver, which you can see a bunch of different versions of on YouTube as well. And I also have those posted on Rehab Central on what a classic one would look like or not. Okay, so let me just pull this forward just a little bit more. Now I sit her up, and then I'm going to show the exact mirror image of that to the opposite side. So we're not going to spend more time on that right now. I think that's pretty self-explanatory. Again, on their shoulder, rotate, and have them look up. And that gives you enough extension, and it gives you their rotation. And it works really well. Okay, so for a lateral canal, you would do a roll test. And again, I'm not going to show that here today, but we do have a link for that. Now, what's these words, canalithiasis versus cupulothiasis? Well, besides making you sound really smart, what the difference is canalithiasis is the classic BPPV that we all learned about. And that means that they are actually floating in the canal, and you're getting the torsional upbeating nystagmus if it's a posterior canal problem, and it will stop usually less than 60 seconds. Now, cupulothiasis is when the crystals are actually adhered to the hair cells in the cupula, and they're stuck on there. So if you can imagine the first version, crystals start floating in the canal, and the hair cells get pulled off kilter, and the crystals are floating, and then when they get to that point where they have nowhere else to go, the hair cells can come back, and the nystagmus and the dizziness stops. In cupulothiasis, they're stuck on that cupula. The patient's in that dependent position, and it just keeps pulling those hair cells, and it keeps facilitating or causing the stimulation that's causing the eyes to do the opposite movement, which is why we use the eyes. A lot of people think that, oh, you can see my inner ears from my eyes. I've had patients ask me that. It's like, no, I explain to them that the eyes do exactly opposite to try and right you. So the information your brain's getting is I'm falling to the left, and the eyes try to right you the other way. And when I explain to them that way, then they're like, oh, okay, that makes sense. Because a lot of people, I use goggles in my outpatient practice, and they're like, oh, they thought the goggles were the magic, Well, I don't have these goggles at home. Is this going to work? It's like, well, it's not the goggles. It's the actual position changes. But they don't get it. So it's important to understand. So that's the two differences. So the reason I put that in there is just because the nystagmus, if it's everything else is classic and it's fitting the picture, meaning torsional, but the only thing that it doesn't have is it's not stopping at 60 seconds. That doesn't mean that it's not BPPV. What that means is that it's probably cupulothiasis, and that's when head shaking and vibration a little bit of a jolt sometimes can get them loose. A little crack the whip action. Not, again, something we want to do with a lot of our patients, but when, if that's the problem, then you just need to be aware that that doesn't mean that it's not BPPV. Okay, so that's what that is. Now that I talked about it, there's your, so how do we treat BPPV? So that's why some people are like, tell me how I'm going to fix it. How am I going to fix it? Well, the proper term these days is now canalith repositioning maneuvers, CRMs. So, and the reason is there's so many different forms that when you say, if you say an epi, it's kind of like we used to say, give me a Kleenex. Well, it's not really Kleenex, it's a tissue. Kleenex is a type of tissue. So when you say I did an epi maneuver, you did a type of canalith repositioning maneuver. Does that make sense? And so when, and again, most people know epi, and that is the maneuver we're going to talk about, and it's still the most commonly used one, most effective, but there's other ones out there, and they have somebody else's name attached to it. Essentially, you're doing a canalith repositioning maneuver. So that's the appropriate term if you want to have the correct lingo. So let's go ahead and look at what a posterior canal problem, and I'm going to talk through this. Let me see if you guys, because the guy explains this real nicely. This is a YouTube video. Oh, look, we have an ad. How do I get rid of this ad? Skip ad. Where is it? There we go. So I'm going to what he's explaining here is that he's showing how that crystal, you see how the canal is nice and smooth. But see that eye movement? That's why this video is really good. That's a torsional upbeating nystagmus. And so here he's showing how somebody could do a self-epi. Well, this is how we do it with patients that want to do it on their own. He's defining this 45-degree angle and 30 degrees of head extension. And again, very well done video. I'd urge you to go back and look at this link, but look at the eye movement. That's what you're going to see, and see how it has a little bit of that torsional component. That's classic, as opposed to horizontal canal, which I'll show you in a second. Again, we're treating posterior, probably going to deal with a lot of horizontal problems. And that is just, he's showing the epi maneuver. Okay. And he actually skipped position 2 here, so I'm not going to, he kind of ran past that. And then the patient has to be able to sit up. So this is where that preparation piece becomes real important for us, is having that assistance around, because for those of you that have treated this, you will, you know that these patients our patients especially are very difficult to get up and move them quickly. We do have to do these position changes quickly, especially the come to sit one, or what'll happen is we don't get it around this turn. And when we don't get it around this turn, then when you sit them up, it just floats back the other way. So this head down position is critical to get that to happen quickly. And I call that position 3. And that's how we get them all the way around. Okay? All right. So again, here I have a video of a modified version of an epi. This is one that's on Rehab Central. And this is, again, me showing how I would do that epi in a modified fashion for that patient that I'm concerned about. So I'll show you. Remember I said if I see it in this position, then I'm going to go straight away and treat it. So now I'm just reiterating what I said before. And then, let me see, I'm going to move this forward just a bit here. So I'm getting her in position. And this is going to be, again, the modified version. Now you see how I already prepared I know that I'm going to end up rolling her to her left. And so I've already set up that way so that when she's done rolling, I'll be ready to sit her up. So you have to plan your rolling and your maneuver a little bit ahead of time, or else you can get in trouble, because a lot of our patients cannot sit real well long sitting. So side lying, head up. I'm going to look for the nystagmus. If she has it, I'm going to wait the full minute, and then I'm going to go straight away, and I'm going to then do my second position after a minute or so, and I'll show you how that looks. And I don't keep her there a full minute for the sake of the video. And I'm always kind of trying to keep their eyelids open. You know, when you see the excessive blinking or anything like that, that's usually an indication that you have something going on. They may not always feel dizzy. We saw a guy in Nashville last week who had some significant path swaying problems, and so I went with the therapist. We put him on the mat. He had dramatic nystagmus, not an ounce of symptoms. I'm not dizzy. I'm not dizzy. And his eyes were just going classic torsional nystagmus. So again, you can't always trust what the patient says. You need to just check it out. Okay, Andrea, let's roll her already. There we go. So again, I rolled her all the way over on the other side, and then I tipped the head up. So for those of you that are familiar with the classic Epley maneuver, which we didn't review in here, but again, we have a link for that, and you can see it also on the links on YouTube. That would just be back on their back and head rotated. Here, I modified it because this is not really any different than what she's doing lying on a pillow, because she told me, this patient particularly told me, she's sleeping on one pillow. So I know that I'm not going to be hurting her neck, and I also ruled out vertebral artery problems, so I'm not really worried. Then I'm going to hold it, and then I'm going to roll into position 3, which is the one I told you that has to happen fairly quickly. Now, I like supporting their head because this is where they will frequently fight you. They're afraid they might roll off the mat. I usually like having another person on that side of the mat so that they don't they're not fearful. But it's about 135 degrees, not straight down. It's about 135 degrees looking down. You're going to hold it. And this one here, if I get a sudden burst or they go, whoa, really dizzy, that's usually a good sign. That means you're getting it around the turn. So this is a critical position. And that's what I'm talking about here, is what we refer to as a secondary burst. And then that's good news. And then you see she's ready to get up. But the other thing they like to do is when you're getting ready to sit them up, they like moving their head up out of position. You see how I'm not letting her move her head, and then I sit her up quickly. That is also critical, that the head stays stationary and everything else get in position for them to sit up. Then I sit them up, and don't let them look up or look down at that point. You want to keep their head level. So that's how that one works. That's a modified maneuver. All right. So there's also several other maneuvers. You see, we call them the Italians, but we're not going to learn these here for the scope of the lecture. And then this other YouTube link is the one we just saw. The CMOT maneuver, which is also quite popular, is a from one side to another. We're not spending any time on that. That ends up being really effective when you have the Cupulothiasis, when they're stuck, because literally you're going from one side and whipping them all the way over to the other side, and you can see how popular that would be in our patient population, right? So usually not a maneuver of first choice, but is very effective if you have the Cupulothiasis problem. So lateral canal problems are treated with what we refer to as a barbecue roll or a modified barbecue roll, or a, I'm going to show you this one real quick so you can see the difference in the nystagmus, because I think that that's, and I've seen this a lot. It's referred to also as a Lempert maneuver, which they're actually roll all the way over. We don't do that with our patients. We would only do a partial or a modified. Where's my... So this is a horizontal. He's talking about the same stuff that you had before. I want you to just see the eye movement. He's talking about crystals floating, same thing. Where's the eyes? Okay, so do you see? Now here they just turn their head to the side, and the elderly, I always do a full roll to the side because I don't want to have any cervical issues getting in the way. So look at the eyes. This is what you'll see. It's a true horizontal, as opposed to what you saw before had a torsional component. And I've seen this in quite a few of our patients in the clinic. So again, he'll talk about how to hold the positions. We don't do the full barbecue roll. We'll do a modified version. And again, I didn't address that because it's a little bit beyond that scope. But if any of you need any help with that, you could always email me and I can walk you through it with a FaceTime or a Skype consult. All right, anterior canal, as I said before, very rare. I don't really want you to worry about it. It's an epi and extreme extension, but we're not recommending this for our patient population because of neck and orthopedic issues, rheumatoid, and all that stuff. So we're just going to go on. So what's a typical treatment? Well, first of all, always rule out vertebral artery, and any cervical pathology. Shunts need to be cleared by the physician before doing any of the testing. Okay? And we talked about why. The Dix-Hallpike maneuver, that's the DHT or modified Dix-Hallpike, is what you use to determine which side is involved. Once you've established that based on your testing, if you find strong nystagmus in your first DHT position, which we refer to that as either head hanging right or head hanging left, or you can call it a right Dix-Hallpike or a left Dix-Hallpike. As I mentioned, usually I'll go straight into treating that because I already have these crystals on the move and we have a very limited amount of position changes that we can do with our patient population. And there's nothing wrong with going straight away and treating it. So you're like, well, what if they have it on the other side too? Well, then they do, and you're probably going to irritate the other side in the process. You can see it because the nystagmus would reverse. So if you put them in head hanging right and you have nystagmus, torsional upbeating nystagmus, and you decide I'm going to go ahead and treat it, and you start a right epi maneuver, and then you go to position 2 for the right epi, you're going into position 2, which is now head hanging left. They'll continue to be dizzy, but if you see the nystagmus actually reverse, that means they have it on the left too, but now you have to stick to your guns and you have to continue with your epi maneuver to the right, which means now you're going to roll to the left and you're going to sit them up. And then you will continue to do as many trials for that right posterior canal as you need to. You're not going to then say, okay, now we're going to treat the left. You don't do them in one sitting. You're going to treat one side, one day, one treatment. And then you now know that you can go back and treat the left side the next day. Now, in a classic vestibular clinic that are dealing with a younger population, they'll do a right DHT, they'll do a left DHT, they'll do a right roll, they'll do a left roll, and then they decide which one's the worst, and then they go from there. Well, we don't have that kind of time, and we don't have that kind of position change options with these patients. So that way, and when I do have an elderly person in an outpatient clinic, that's exactly what I do. I pick a side, I lay them back. If I see the classic nystagmus, I treat it. And a lot of times I'll have it on the other side too. And I explain to them that, look, you have it on both sides. We're going to focus on this side today. And then tomorrow or the next day, we're going to go to the other side. And they're usually okay with that. As long as you're not acting all surprised, and as long as you're not like, oh my gosh, you're so dizzy. Oh, you're throwing up. Oh, I've never seen anything like that before. That is not what they want to hear. Okay. What they want to hear is this is what's going to happen. You're probably going to get really dizzy, but it's okay. It will go away. And then all of a sudden you're like, you're a fortune teller because you said it was going to go away and it did. So you want to gain their confidence. And the next time I do it, it'll probably be less. But because you have it on the other side, we could be irritating it. So I explain all this to them and then they're good with it. But if you act surprised, like, wow, I've never seen anything like that before, that is not what they want to hear. Okay. Now, sometimes you may see something that you've never seen before, but I would strongly recommend you not say it out loud, make that an inside voice, because that is not what these people that are spinning out of control want to hear. Okay. So go ahead straight, and if it's undisputable strong response on one side, go ahead and treat it. So as I talked about all that. Okay, so what are we going to document? So here's some examples. You want to always talk about the latency. So you want to say something to that. You don't want to just put in your notes, patient was dizzy, so I treated them for their dizziness with an epi maneuver. we want to be a little more skilled than that, okay? So you're going to say the latency of the nystagmus, so how long did it take before you saw it? How long did it last? Duration of the nystagmus was 20 seconds, okay? And you may then say, looks like canalithiasis, or duration of the nystagmus is greater than 60 seconds, may be cupulothiasis in your assessment. Did it decrement with repetition? That is, remember, one of the hallmarks of BPPV, so you're going to want to put that in your notes. How did they respond to the canal 3 positioning maneuver? So you're going to say perform canal 3 positioning maneuver, how many trials you may have done, but then you want to make a comment on how they responded to it. Responded well, symptoms continued to get worse, symptoms improved by 3rd trial. Those are kind of things you want to talk about. You're going to want to say which canal you treated. You're not going to say, well, it looks like patient had BPPV, so I went ahead and just decided to throw in a couple of maneuvers. I had no idea what side I was doing. We want to say, patient demonstrated positive Dix-Hallpike on the right for posterior canal, treated posterior canal with canal 3 positioning maneuver, did 3 trials. So you're showing that you're being diagnostic and that you have a plan. It's not that you're just willy-nilly rolling them around. And I see that a lot. I have a lot of patients. When I was doing this in outpatient, I would have people come to me that had been in the ER, that had been to ear, nose, and throat specialists, neurologists, and they end up finally coming to us. And the stories were horrific that these people would tell us that the physicians would do, and they would just look it up on the internet and they'd miss a position change, or they'd just tell them roll back and forth 5 times, they would say, or I want you to bend over, look up, and all these poor people do is making themselves sick, sick, sick. So what I want you to understand is that's why it's important for us to show in our notes that we actually are specialists in this area and we're looking at specific things. And then you talk about the number of trials performed. So it sounds like it was a lot, but it doesn't have to be a lot. So under the objective, I could say right Dix-Hallpike was positive. We noted torsional upbeating nystagmus. The latency was 5 seconds, duration was 30 seconds. Patient was treated for a right posterior canal BPPV with modified canal through positioning maneuver for their posterior canal 3 trials. The nystagmus completely extinguished by the 3rd trial. So all of that stuff that I just talked for the last 3 minutes, you say I put into a very concise short paragraph. Under the assessment, I could put head hanging left, position 2, demonstrated a reversal of nystagmus, suspicious of left posterior canal involvement. Okay, not a lot of words, but I say a lot in that, right? And those abbreviations, by the way, are very accepted abbreviations in the vestibular world. And so I continue to use those. You see they're in capitals. And so if somebody says, well, what's HHL? It's like, well, that means head hanging left. And if you knew anything about vestibular problems, you would know what that means. But since you don't know what it means, but now I'm telling you that that's what that means. So I'm just saying that a capital NY, these are all standard acceptable abbreviations. Under plan, I'm going to say I'm going to assess the patient's symptoms in response to the canal 3 positioning maneuvers next session. And I'm going to treat the right posterior canal if the right DHT is still positive, and possibly treat the lateral canal as tolerated. So again, that's a pretty typical note, but I'm stating that. So here are the links, all of the Rehab Central links that I would encourage you that are specific to BPPV. Those are listed. There's a bunch under the balance section. These are specific to BPPV. Here are the YouTube links that we had. Again, cut and paste them. And they're really well done. They're not very long. So I would encourage you to rewatch them. And I'm going to go ahead and open it up to questions, and I will unmute all of you right now. So give me just 1 second.